We are live.
Good evening. We are back with our walk-in patient series, which happens every second Saturday and addresses very common clinical problems. As you are aware of, episcleritis and scleritis happen to be common clinical conditions, and sometimes the diagnosis can be confounding and the treatment very variable. So today we address these very common clinical issues, and of course, Somashila Murthy is the program director, and she has worked hard to put together this wonderful program. Dr. Atinam from Arvind Eye Hospital, Madurai will be the chairperson along with Dr. Partha Biswas, and Somashila will be the main moderator. We have panelists, Dr. Anup Kelgaonkar from LVPI Bhubaneswar, Mayur Morekar from Bombay Hospital Institute of Medical Sciences, Mumbai, Partho Pratim Majumdar from Shankanitralaya, Chennai, Sanchita Mitra from LV Prasad Eye Institute, Hyderabad, and Vedana Aiki from Arvind Eye Hospital, Madurai. And the presenters are Archana Singh from Kanpur, Fatima Fahima from Shankanitralaya, Chennai, Ronnie Abhishek from LVPI Vijayawada, Supriya Sharma from Shantilal Sanghvi Eye Institute, Mumbai, and Zahra Mustafa from Bombay Hospital Institute of Medical Sciences, Mumbai. And that's the program for today. We have several cases with interactive panel discussion. I hope everything goes well. Thank you so much, Sheila, for putting this together. You can take it.
Thank you very much, Dr. Honavar, and this has been a wonderful opportunity. Thank you to AIOS and to Dr. Honavar, Dr. Partha Biswas, and Dr. Mathur for giving us this wonderful opportunity, because I think episcleritis and scleritis both are very neglected diseases. So today's program, I'm certainly very excited about. And we do have a keynote by Dr. Ratinam, but maybe Madam there's some technical issue. So what we'll do instead is that we'll start off the batting with our cases. And I'm going to make a slight change in the order of cases. We'll first start with Mayur, because his case deals with episcleritis, and then we'll go on to Ronnie. And Partho, and your case, we'll take it up towards the later part, because yours deals with posterior scleritis. So that's the order. So it is like our best batsmen, like batsman number 1 and 2, and first should come in the good batsmen. And then in the very end, you have all the fast bowlers. So that's how it's going to be today also. So over to you for the first presentation, which will be by Dr. Zahra Parekh. Zahra, are you ready?
Yes, ma'am.
Excellent. So Zahra is, Mayur, would you like to introduce Zahra to us?
Yeah, so Zara is our second year resident. And first up, I would like to thank Dr. Murthy and AIOS and Dr. Santosh Honavar for giving her this opportunity. I think as a second year resident, this is a tremendous opportunity. Over to you, Zara.
All right. So the format for today for the cases is that we'll have the presenter take about 6 minutes or so to walk you through the case. So the patient walks into your clinic, and so the presenter will walk you through the case. And followed by, maybe the presenter might pose a few questions, or certainly I and the chairs will definitely pose questions to the discussant. So the first case is by Zahra, and it will be discussed by Dr. Morekar. Please go ahead, Zahra.
Okay. Good evening to one and all present here. I'm Dr. Zahra Parekh, Junior Resident 2 at Bombay Hospital, and I'm presenting my topic along with Dr. Mayur Morekar, sir, Associate Professor at Bombay Hospital. My topic for today is not just another episcleritis, unmasking syphilis, and underscoring the crucial role of a detailed retina examination in episcleritis. So there was a 45-year-old woman presenting to our OPD with a 15-day history of bilateral ocular redness and pain. This was gradual in onset and persistent in nature, not associated with any trauma, discharge, blurring of vision, or photophobia. No systemic symptoms such as joint pain, skin rashes, or any oral ulcers were reported. No history of any systemic illness, surgeries in the past, and drug allergies. No significant family history. She was evaluated and diagnosed with episcleritis elsewhere and started on loteprenol eye drops 0.5% eye drops 4 times a day, and Nepafenac 0.1% eye drops 4 times a day. So on clinical examination, her best corrected vision in both the eyes was 6/6 part N6, color vision normal, Amsler grid normal in the right eye. In the left eye, there were wavy lines seen inferiorly. Intraocular pressure was normal. Extraocular movements were normal. No painful extraocular movements were present. So on slit lamp examination, the cornea was clear in both the eyes. There was bilateral episcleral congestion, which was seen sectoral in distribution, superiorly in the right eye and inferiorly in the left eye. There were bright red, radially arranged vessels, which blanched only minimally on application of 10% topical phenylephrine. Anterior chamber was quiet, no cells, no flare, and pupil was round, regular, and reacting to light. So now we dilated this patient, and on fundus examination, this was the picture that was seen. There were multiple yellow-white lesions all over the posterior pole, especially around the macula in the right eye. And in the left eye, there was a single irregular yellow-white lesion which was seen just superior to the fovea in the left eye. Rest, the disc was normal. The disc margins were distinct. CD ratio was 0.3:1, and the blood vessels appeared normal. Now, to confirm our fundus findings, we did an OCT 21-line raster on which, in the right eye, we can see attenuation of the ellipsoid zone is seen, along with hyperreflective dots in the inner choroid. Similarly, in the left eye, here we can see again attenuation of the ellipsoid zone, which is seen. Now, the patient came to us with a few investigations done already, which was CBC showing a raised WBC count with neutrophilic predominance, a raised ESR. The blood sugar and urine report was normal. Mantoux test was positive, 16/14 mm after 48 hours. IGRA was positive, anti-CCP negative. VDRL was reactive, 1:4 titers. The chest X-ray was normal, and the HRCT showed prior granulomatous infection, which was confirmed to be inactive. Now, based on the clinical picture, the fundus photo which showed acute posterior placoid chorioretinopathy like a picture and confirmed OCT findings. We did only 2 tests. One was the TPHA, which was positive, 1:64 titers, and the triple H, which was non-reactive. So, because the diagnosis of syphilis was confirmed, we admitted the patient mainly because the lesions were close to the macula and we wanted to monitor her serially. So we admitted her and started her on injection ceftriaxone 1 gram BD and injection dexamethasone 10 milligrams once a day. On the 4th day, her episcleral congestion began to resolve and the lesions began to scar, so we discharged her. And on discharge, we gave her injections ceftriaxone 1 gram BD for 10 days and started her on tablet prednisolone 40 milligrams once a day and tablet pantoprazole 40 milligrams once a day. On the 7th day, her episcleral congestion had completely resolved and all the fundus lesions had scarred. But this is the picture after 1 month where there was still no episcleral congestion and all the fundus lesions remained scarred. Thank you. Now, the further presentation will be taken on by Dr. Mayur sir.
Yeah, so Zara, what you can do is you can tell our 3 take-home messages, and then I'll.
So the first take-home message is that it is very important to have a dilated fundus examination done in all patients of episcleritis. Importance of tailored investigations in episcleritis and scleritis, which is very specific to the clinical findings that are seen in that patient. So it varies from patient to patient. And the difference between the VDRL and TPHA test in syphilis diagnosis. So VDRL is basically a screening test, and we can use the titers to monitor the disease activity, mainly as in if the titers of VDRL are declining, it shows a good treatment response. So it's a very quantitative test, and TPHA, it's a very diagnostic test. It confirms the diagnosis, so it is qualitative in nature. Thank you.
Yeah, thank you, Zara. And I just comment this. These 3 were our take-home messages for this case. So this case was first referred to us as an episcleritis. What was good about the entire thing was that the referring doctor had actually seen the dilated fundus, and so it was referred to us saying that this wasn't just an episcleritis. And the fact that we could do OCT and because there was an outer retinitis which was present, we thought of syphilis. Of course, that VDRL test which was positive was a little guiding. But here you note that the patient had a positive Mantoux, the patient had a positive IGRA. The CT was showing old changes of tuberculosis, yet we thought that syphilis was the diagnosis. And therefore, we did the more diagnostic test, which is TPHA. And of course, the difference between VDRL and TPHA, she's already explained it. There is anything specific, Dr. Murthy, that want to have us to take home from this case?
So actually, so this case highlighted what generally episcleritis is not. But the point to be taken from this case is that you must always examine the dilated fundus of all patients, even if it's episcleritis. So what we can do is that, Mayur, we'll go on to Dr. Ratinam's keynote. I think Dr. Ratnam is ready. Sunil or Dr. Ratnam, can you confirm? If we are ready, then we can go on to a keynote, because I'm sure she would have covered about episcleritis and scleritis.
Yeah, I am ready.
Yes, ma'am. So maybe we can have your presentation next. It's my distinct pleasure to introduce. Nobody needs to be introduced to Dr. Ratinam. Everybody knows her, but just that she's the professor of or chief of uveitis and also the head of the post-graduation education program at Arvind Eye Institute in Madurai, and she has more than 30 years of experience in uveitis, and all of you know that she has done stellar work in the field of uveitis. So we are really fortunate to have Dr. Ratinam. Maybe Zara, you can stop sharing your presentation, and Dr. Ratnam could share hers, and she will deliver her keynote on an overview of episcleritis and scleritis, and then we'll go back to you, Mayur.
Thank you. Thank you. My slides visible?
Yes, ma'am.
Yeah.
You can go to full screen.
I'm coming to the full screen. Yeah. Am I audible?
Yes, ma'am.
Okay. I'm extremely happy to be with you. This is a great honor. Thank you for a wonderful introduction, Somshila. Now we are going to episcleritis and scleritis. The most important one is the classification. What do we mean by classification? The first question the first year student of MS always asks is, what is so difficult to differentiate episcleritis from scleritis, ma'am? How do you address that? We will be seeing in the next slide. Then comes the morphological classification, whether it is a nodular or diffuse or posterior or bilateral, unilateral, that morphologically what we see. Then the third most important one is infectious or non-infectious. Fourth, it is almost like infectious, non-infectious, but still you can have traumatic and masquerade also. So etiological classification is also very important. In spite of the fact I have given infectious, non-infectious separate because it is very, very important. The last classification, whether it is associated with systemic diseases or not. So depending upon all these things, you will be having tailored investigation and tailored treatment. So the classification becomes very, very important in case of scleritis and episcleritis. In fact, diagnosing uveitis is much easy because we will have clues in several ways. Whereas episcleritis, scleritis, clues will be less and non-specific signs will be more, and it is difficult to diagnose. And if you all know, I need not repeat, mild episcleritis is mild, painless, and phenylephrine will blanch, whereas here it is intense, painful, and it will not blanch. But I would like to give you something else. See in between the vessels. If you see in between the vessels, sclera is white, it is episcleritis. In between the vessels, if sclera is red, it is scleritis. If you see the next one, see here, in between the vessels, it is red. And here, in between the vessels, it is white. So this is obviously episcleritis. This is obviously scleritis. So coming to the morphological classification, there may be history of foreign body fall, and you may see a nodular scleritis, and this is a localized nodular scleritis versus a diffuse anterior scleritis. Most of the time, the diffuse anterior scleritis will have underlying pathology, may be systemically associated also. Whereas nodular scleritis with the foreign body, fall of foreign body or insect may be easily handled with topical steroid, or you may remove the foreign body. The posterior scleritis, of course, we will be seeing only through the fundus, like optic disc edema as well as choroidal folds. So morphologically, we are just seeing the anterior and posterior scleritis, and etiological classification, as in uveitis, it also comes as infectious, non-infectious, and masquerade. In infectious, as we just now saw, it could be syphilis, it could be tuberculosis, leprosy, and parasitic diseases. And in non-infectious, it could be vigorous granulomatosis or rheumatoid arthritis. In masquerade, we can have Bowen's carcinoma. So all these things are going to look alike, and we will be seeing one by one some important cases also we will see. Here is an elderly man with rheumatoid arthritis with a corneal melt, which means that this patient is suffering from systemic vasculitis with corneal melting and iris prolapse. When I ask the students what they will do, they usually say, the surgeons will be tempted to say excision of the iris and suture. No, we should never do that. And no excision and bandage contact lens. It is vasculitis is the cause. So immune suppress as much as possible, and the corneal melt will disappear, and it has sealed on its own. We have not done anything. We have just started cyclophosphamide in this patient, and it just healed on its own without any suturing. Iris got incarcerated. But however, patient vision was salvaged. And vaginous granulomatosis is also a very major autoimmune disease which causes scleral melt. Or previously we saw corneal melt, and this is a scleral melt. And rituximab is one of the fantastic drug to control this. Patients who cannot afford for rituximab, cyclophosphamide is the God-given drug for this granulomatosis polyangiitis. Here is an elderly man with granulomatosis polyangiitis, but treated for 6 months as chronic conjunctivitis, and a course of cyclophosphamide healed this patient. He was positive for CANCA as well. And this patient too, actually nodular scleritis. In between, you are seeing the white area, but the two areas here is scleritis, it is nodular. And on careful examination, the pinna was inflamed. It was relapsing polychondritis, which needs immunosuppressive even in the first visit. Here is another important patient, a very, very interesting patient, referred as a case of Flickton. Flickton will not be present at the limbus, and this is at the limbus. And further, she was not otherwise normal, man to 10, X-ray normal. What she had is leukoplakia, and fingers were showing some shiny lesions. And ESR was 70, ANA was positive for scleroderma. After immune suppression, her quality of life improved so much with the disappearance of signs as well. So we have seen already that there are 3 groups: non-infectious, infectious, and masquerade. And you will agree with me, non-infectious, we only control inflammation, prevent sequelae, whereas infectious specific treatment should be given. And in masquerade, we always refer the patient to the oncologist. So to take the non-infectious first, we always give steroid, immunosuppressive, and new biological. The most important message in this slide is, look for the infection always, because infection can mimic a non-infectious uveitis, or infection can occur during your treatment with immunosuppressive. Even though the patient suffers from autoimmune disease, they may develop an infection in the eye. The next case is a best example for that. I'll tell you, this patient is a diagnosed case of a SLE patient, and patient had 4 cycles of IV cyclophosphamide, and then she developed this episcleritis, and referred as a case of complication of SLE. But what happened is, soon she developed diffuse anterior scleritis and followed by scleral abscess. In this stage, her ANA was negative, ESR was normal, systemically absolutely controlled SLE, but appearance of scleral abscess tells that it is not the routine SLE, SLE complicated with opportunistic infection, tuberculosis. So we excised and it was tuberculosis positive, the stain was positive. She underwent enucleation because the whole eyeball was full of pus with tuberculosis. This is a very important, interesting case again. The patient had severe headache because of sinusitis. In spite of ENT surgeon's opinion as sinusitis, this patient wanted to go for alternate treatment. So he went for a pranayama training, and where he was asked to breathe forcibly with closed nostrils and closed mouth, which was Valsalva maneuver. And what happened is, he had a infectious sinusitis, which spread to the orbit, and he came with orbital, scleral abscess. We incised the scleral abscess, and it was Pseudomonas sinusitis and Pseudomonas scleritis, and specific treatment was given, and beautifully we healed the scleritis, and this was a wonderful case. And the reason, in 2006 to 16, there was a study in Bascom Palmer, and they told that post-surgical scleritis is very common after pterygium in their center, and the Pseudomonas scleritis was common. This was followed by another study that also said that Pseudomonas scleritis is common. Whereas LVP conducted a beautiful study in their paper. It was post-cataract surgery, and fungus was predominantly seen, fungus and nocardia. And this study was from 2000 to 2005, which was followed by the second paper. And this paper is also a wonderful paper where the post-surgical scleritis do exist after scleral buckle. So it doesn't matter whether it is scleral buckle or cataract or pterygium. We do have surgically induced scleritis, and our spectrum is like fungus. In this paper, fungus followed by staphylococcus and nocardia. Pseudomonas comes in the fourth position. So we have to be aware of this surgically induced scleritis. And now I am going to show you few very rare organisms. This young man had a fall of insect in the eye, and a scedosporium was grown, the fungus, and with voriconazole, it healed so well. So the isolation is very, very important, even though it is very difficult. And this patient had Staphylococcus aureus MRSA infection, very poor hygiene, and had endophthalmitis as well. Because of endophthalmitis, he had very poor prognosis. This patient was suffering from alkali genes fecalis, and there was a foreign body here. If you see, there is a foreign body here in UBM, and he was treated. Again, this scleral abscess was drained, and organism was found out. Then, depending upon the sensitivity, the treatment was started, and it resolved beautifully. This was a Enterococcus scleritis. This was sensitive to moxifloxacin and treated, and this is the after treatment photograph. So tuberculosis can also cause scleral abscess like this, and this patient had a cavity. And one important thing is, tuberculosis can cause cavity, nocardia can cause cavity in the lung. Also, the vaginous granulomatosis can cause cavity in the lung, and all the three causes can cause scleral abscess or scleritis. So we have to be very cautious to differentiate TB, nocardia, and vaginous granulomatosis. So this case, we isolated the tubercular bacilli. And nocardia, see, as I told you, this patient had a cavity, but nocardial cavity. So the treatment-wise, it is just north and south. If it is autoimmune, it is the extremely opposite side. Infectious, it is the other side. We have to have a map, but often the infectious, we will be thinking that it is infectious, then we will be surprised to see that it becomes autoimmune disease. So we have to be careful throughout the course of the disease. Isolation is very, very important in case of infectious. And in autoimmune, as you can see, so many organelles are there and antibodies are there. And it may be antibody to centromere or DS antibody showing SLE. These are some pictures of autoantibodies. When we have that, we have to have a specific treatment. And always remember, we have to be cautious when we are using immunosuppressive. Thank you. Thank you for your attention.
Thank you so much, Dr. Ratnam. That was a rather brief presentation. I was hoping that you would, and your spectrum of cases is just amazing, and so was the way in which you have described it. One slide is so important in the entire presentation. So going back to where we had started, that is, we had started with episcleritis, and Zara had presented her case. But her case was very different in the sense that the main case was not at all the episcleritis, but it was a case of syphilis. So to be a purist in terms of how we name our patients with inflammation. So in that case, I would have the diagnosis for that patient, episcleritis doesn't feature. It is one of the inflammatory signs, perhaps, but that would be a case of posterior uveitis or whatever that could have been relabeled in that way. But coming back to episcleritis, which is a very common entity that many general practitioners are seeing, and I think even during COVID time, most of us have experienced that a lot of patients staying at home, we would do teleconsultation and they would have sort of almost like there was a spate of episcleritis in many of our patients. So it is a very common condition. I don't know the exact incidence, but a lot of general ophthalmologists do come across. So my question first, I will ask Dr. Ratina, is that a walk-in patient comes into the clinic with episcleritis, and you have mentioned some clinical points. Zara has mentioned some clinical points in terms of how to differentiate between episcleritis versus scleritis. So let us say that now you're very sure that it is episcleritis. So how do you manage your patients with recurrent or maybe even first episode of episcleritis?
Yeah, first episode of episcleritis. Actually, all the patients we do TCDC, ESR, CRP, MAN2 and VDRL. The reason is MAN2 we don't suspect TB always, but we don't want the patient to have background TB, and we will be landing up with problem when we start steroid. MAN2 becomes irrelevant. And ESR, even though it is less specific, it will give us some clue whether the systemic inflammation is going on or not. So the basic investigation will be done. And if it is first episode, definitely we just treat with topical steroid. We don't give anything, but the history is extremely important. Whether they have any associated joint pain, chondral pain, or any other, like even like vagus granulomatosis, patient may have severe headache or mastoiditis, or patient may have chronic cough or renal problems. So every case of episcleritis and scleritis, all the system questions should be asked. Finally, I add one more question. Have you ever had any problem in your life? Because they always say, no, I'm all right, I'm all right. Have you ever had any problem? Have you ever met the doctor? Because I never believe them when they say no. So then they will come out, yes, I had cough and I went to a doctor. So history is very important even in the first visit. Then when recurrent cases come, I start doing autoimmune workup as early as possible.
So that is because, Dr. Ratnam, one thing would be that where you're practicing from, you're practicing at a tertiary care eye center, and you get a patient with a lot of referred patients, and they probably you may not get the patient just coming into a general practitioner, like a general ophthalmologist practice. So I'll come back to Mayur, to you, because of the case that you described, and great case and great learning pearls that we must always examine in entirety. And from Dr. Ratnam, we have learned that you must have at least on your mind and on your radar, that there could be some underlying systemic disease, and take a thorough history. So these are very simple things that all ophthalmologists can definitely do, to do a complete examination and take a thorough history of any systemic disease. So Mayur, if you see a patient that now you have determined is episcleritis, so what is your treatment algorithm for these patients?
So more or less like Madam said, if it is the first episode, then I would be trying to treat the patient, of course, with topical lubricants. That's one thing. Maybe topical NSAIDs. If I feel that I need to use topical steroids, then I would use a soft steroid like loteprednol. What happens in all these patients is that when they come to us for the first time, somehow the episcleritis is something that again, just as Madam said, the history part is the longest with episcleritis, because you can have a myriad of systemic diseases that could be associated with it. So the history part is extremely intensive. From the treatment point of view, first episode, you just try to give topical treatment in terms of NSAIDs, lubricants, and steroids. One thing that I do, which probably is a little different, is that while I'm tapering the topical steroids, and if I'm sure that I'm dealing only with an episcleritis and there are no real systemic diseases that one is dealing with, and if there is a little relapse, then what I do is sometimes I add topical cyclosporin to that treatment regimen, just as a sort of a steroid sparing agent. That's one thing that I do differently. Having said this, this is a condition where at least a basic, if it is a recurrent, at least a basic ESR and CRP should be done, because that gives us a rather rough idea of what could be happening. Mantu again is something that I do. I also do TSH level and uric acid level. Especially if they are males, then I would do uric acid, because a lot of them are into fitness, and therefore they are into some form of proteins, and therefore their uric acid levels are sometimes high, and that gives rise to episcleritis.
Ratnam, Mayur sees the other side of the community. He sees a very high-end patients. Most of the patients we see are barely making ends meet and don't have food to eat, and there they are on a special high-protein diet. So there's a huge difference, but it's good to get his perspective as well. So we'll keep on bugging you, Dr. Ratnam, throughout the presentation. And episcleritis by itself is a complete, different discussion. And so, for example, the cornea, we are 3 cornea people here. For a change, we are pretty strong. There's Dr. Archana and Supriya and myself. So I think the 3 of us also see a lot of cases of episcleritis. So I'll just take one comment from Archana, and I do have to get one question answered, Mayur, so hold on. So Archana, you must be seeing a lot of cases of episcleritis. Do you do immune workup? What do you do in your cases?
If it is like the first episode, then I do take a detailed history. So if the history is suggestive, then yes, I go for immune workup. But if the history is not suggestive, like Dr. Mayur pointed out, the history has to be the longest. So in my cases also, the history is the longest. So if the history suggests, I go for a immune workup. If it's not, then just a course of soft steroids and then I monitor. If it's recurrent, then yes, I will again go for immune workup then.
Okay, thanks for a quick answer. Mayur, a quick question for you was from the chat. So Dr. Raju has asked that in that case that was presented, why you did not think of TB and start treatment? Why did you think of syphilis?
So the only reason there was that to me that retinal picture did not look like TB. In fact, what we did was we did an OCT and we did a 21 line raster, because basically we wanted the lines to go through each of those lesions. And in the left eye, there was just a single lesion, so we could pass it through those lines. And what we saw was outer retinitis. And with TB, what we would have expected was a choroiditis. So when we saw that outer retinitis and not a choroiditis, that is what made us think that it was syphilis.
So basically you dilated, you saw the lesion, then you did OCT, that gave you the diagnostic possibility of a retinitis, and then you went on to investigate, and that confirmed your diagnosis.
Yes.
So there may be a coincidental Mantoux being positive, which is, I mean, it's there in many patients. So Partho has a point, and after Partho's point, we'll go on to the second case.
Thanks, ma'am. I think one most important point we should highlight is that we confuse sometimes the episcleritis between scleritis, because all of our patients consider the discomfort, ocular discomfort, as a eye pain. So a patient with episcleritis sometimes will come and will tell that I am having eye pain. So I think we should ask a leading question to the patient: is it the pain so severe that you had to take NSAID? Because this discomfort, sometimes they can't describe properly. And second thing is that it's always important to tell the patient that this episcleritis most of the time is like a social nuisance. The patient actually does not care about that, but somebody will tell why your eyes are red. What is happening? So you need to tell them that you need to better to take the NSAID. Sometimes you prescribe topical steroid and they get so comfort that their eye has become red, no? So they start without consulting the doctor, they continue taking the topical steroid. And sometimes they land up with other complications like cataract and all. So you see, most of the time, these are the patients coming with secondary glaucoma or cataract, because they are not going, they stop going to the doctor, because they know that if they put this drop, the eye becomes wide. And I think this awareness is very important for the patients with episcleritis.
So basically, patient symptoms that the patient doesn't really have severe pain, that is obvious. The attendants or family members are more concerned in the patient. That is one more factor. And as Archana pointed out, that she takes a thorough history and then basis which she decides. And we've heard that start off with lubricants, NSAIDs, soft steroids, and only then go on to whole steroids. And in these patients where they just have a sort of a garden variety episcleritis. So Priya, perhaps you could be the best person to talk about cases which look like episcleritis, but maybe something else on the surface, lids or whatever. So it looks like episcleritis, but it's not even scleritis or episcleritis.
Yes, so thank you, Dr. SS. We do get a lot of patients come with this recurrent redness, often being treated as episcleritis. And one clinical diagnosis that is often missed is blepharoconjunctivitis, because we often tend to miss the eyelashes, and these patients have severe squamous blepharitis that gradually leads to blepharoconjunctivitis. But then again, we have to this basically is to highlight that it's important that we look at the eyelashes. And we also look at, so in long-standing recurrent cases, these patients will have corneal scarring, vascularization involving the corneal periphery. And this is one of the closest differential that I feel episcleritis has.
Yeah. So when you have patients where the congestion or the redness is not going away, differential diagnosis should include possible demodex, blepharokeratoconjunctivitis. Patient can have dry eye, and different reason for the dry eye, but can have sort of a redness that doesn't go away. Drug induced, both topical as well as systemic drugs can cause this kind of congestion, and even chronic smokers. So many reasons, thyroid eye disease. So these are many reasons why you can have something looks like episcleritis but does not go away. So it is important because these are patients who will often walk into clinics, at least at the first entry level. So thanks to everyone for contributing towards episcleritis. And now,
I think, MGD, I think MGD is one of the main, any ocular surface, but quite a few times missing an MGD will keep coming back with the episcleritis. I think as maybe we are covering it with NSAID and lubricant, which is taking care of the MGD. We are just treating them as episcleritis, but the main cause could have been the MGD from the beginning. So I think even that has to be addressed when we look at the reason for.
So we shift gears and we'll go to batsman number 2 and 3. And this is going to be Ronnie, who's going to present his case, and Anup is going to discuss the case. Over to you, Ronnie and Anup.
Thank you, Dr. Murthy. Good evening, everyone. Today I'll be discussing one case of anterior scleritis under the title Red Eye Deep Nocturnal Pain, a case of scleritis. And this case will be discussed.
Slightly unclear. Can you just speak clearly? I'm not sure if it's just me. I think you're not that clear.
So, is my voice breaking, Dr. Murthy?
The voice is not breaking, but it's just that you were not clear. So maybe
clear. Okay. I'll speak a little louder.
So
this case will be discussed by Dr. Anup Kelgaonkar, faculty and HOD, uveitis and vitreoretina services at LVPI Bhubaneswar. So our patient is a 50-year-old female from Odisha, came with chief complaint of redness in the left eye since 8 months associated with headache. So on further inquiry, she mentioned that the redness is associated with deep pain more during the night and also blurring. She was diagnosed with left eye nodular scleritis in an outside facility, and she was started on atropine, napafenac, and prednisolone eye drops. So further eliciting, her first episode was in May 2023, and she did not have any associated inflammatory joint pain, no TB contact, no skin rashes, no hemoptysis, epistaxis, or sinusitis. The first episode resolved with tablet etorecoxib 60 milligrams and was started on sulfasalazine because her rheumatoid arthritis factor was positive at that time. Even though her HLA-B27 HIV were negative, here ESR was 135 millimeters at first hour. And these are the investigations that she carried when she has presented to us. Our vision in the right eye is 20/20, while in the left eye, best corrected was 20/25 parts. And the right eye anti-segment was unremarkable, while in the left eye, we can see there is diffuse scleral congestion along with dilated blood vessels. There is one area of suspected nodular elevation. Anterior segment had resting on the endothelium. There were 2+ cells, and there is a broad posterior synechia inferiorly. Grade NS2 cataract is present. And when we looked at the fundus, right eye fundus was normal. When the left eye, there are vitreous membranes which appear to be resolving, and there is hyperemia of the disc, even though the rest of the features were, may not be clearly visible at that time. So we did a B scan as well, which showed consolidated vitreous echoes, but there was no much of choroidal thickening. So with a provisional diagnosis of left eye diffuse anterior scleritis with non-granulomatous anterior uveitis, we investigated the patient for C-ANCA, P-ANCA, ESR, CRP, and complete urine routine examination, and started the patient on etocoxib 90 mg this time, along with prednisolone and atropine eye drops. So when she had come back with those investigation results, her C-ANCA was positive, ESR was 85, and complete urine routine examination was normal, within normal limits. We further added the treatment with oral steroids, 60 mg 2 weekly type, along with methotrexate and folitrax. Sorry, methotrexate and folic acid. And within a span of 2 weeks, we can see that the congestion has resolved very much, even though the dilated blood vessels are still present. And we can also notice the areas of thinning, the bluish hue which is present, is coming up now. And within a span of 2 months, the congestion has almost resolved, and eye is quiet. And later, after a period of 6 months after starting methotrexate, we have taken up the patient for cataract surgery. During the perioperative period, we started the patient on IV methylprednisolone on the day of surgery, as well as post-op day one. Increased the methotrexate to 20 mg, and also stepped up the post-op oral steroid regimen. So this is 6 weeks post-operative period, where the vision is 20/20 and 6, and the eye has been quiet. So my questions to the discussion, Dr. Anu. So what symptoms should we ask, and how do we elicit the history when we see a patient with diffuse anterior scleritis?
Yeah, that's fantastic case, Ronnie. And if you could go to the first slide where we had scleritis, wanted to highlight a couple of points there. And Ratina ma'am has already explained many of the findings in and history taking in her, and she nicely put out many points. Sometimes, you ask patient for old lung injuries. So sometimes they might have acute lung injuries, acute renal injuries, admission for maybe they get admitted under pretext of a pneumonia, which is probably a vacuole there and things like that. That's point number one. The second point that I wanted to highlight was you see a whitish area in the right picture of yours. Yeah. And so about 7 to 8 years back, Ratina ma'am was traveling in Bhubaneswar. Basu sir was there. We're seeing a case. And then I learned it there that, a area, a whitish area within an area which is very reddish could be a sign of early necrosis. And what we need to see is, so generally you see scleritis on a diffuse light examination, see that the superficial vessels are congested, dilated, the deeper vessels are engorged, dilated. And then when you go to slit lamp, what you need to see is, as you shown in the slit lamp image, the widening of the two beams where we have a scleral edema. And the second thing is, if you look at these whitish areas, you'll get to see kind of an occlusive vasculitis kind of a picture where the vessels shut down when going to this white area. And then you know that, what you're seeing is a probably a setting in necrosis. So even before it picks up, it sets in, you pick up. Now, there is one confusion. Sometimes you can get confused these necrotic areas with a pus-like picture. So you might think that, this is an infectious scleritis. Now, what I find it's a very subtle difference. Sometimes you might not get it. Imagine a fundus fluorescein angiography where we have occlusive vasculitis, closing down of vessels. The similar thing happens if you magnify the view and go to near that whitish area where the necrosis is happening. While in a case of a pus, there will be more and more vasculature going onto the pus, which is generally, to cover and heal it. So that's the second point. Then if you could go to the slide where you showed vitritis, very rarely cases of Cianca which are untreated can lead to such a slightly haze and vitreous. And the next point was your investigation slide. And I wanted to bring into the notice of our listeners that the Cianca and Pianca, when you write these tests, we nowadays prefer to write it by ELISA method. So you could write PR3 MPO, or the older method was ANCA by immunofluorescent assay, but PR3 and MPO are much more now better choices to give, and rheumatologists have a recommendation to that as well. The last point I wanted to say, Ronnie, was that keep an eye over these patients for their lungs and the kidneys. So in their, even years after, the scleritis might have stopped, but they might have sometimes renal troubles or lung trouble. So they need to have that paper with them that says that they are a case of GPA, and let their physician know that they have. um, Sometimes there are practical difficulties in starting cyclophosphamide and rituximab. Most of the times I keep that options open with a rheumatologist, and sometimes there are financial troubles, such as in this case, where there is at times a limitation to do cyclophosphamide or rituximab, which would be very ideal in such cases. And then the last point was taking up these cases for cataract surgery is a very trick. You have to pick up at the point at which you take these cases for surgery. Before the cataract is too hard, probably you and Somshila ma'am would be the best person to tell when to take a healed scleritis for cataract surgery.
So, one more question, Dr. Anup. Should we test for Cianca and Pianca by ELISA or MP3 PRO?
So that's
Uh,
what I think we should go for, and that's what more and more rheumatologists now prefer to do is an ELISA, which is essentially a MP3, MPO, and PR.
MPO, PR.
Yeah.
So, we in this patient, the rheumatoid arthritis factor was positive. And that is the reason why the patient has already been started on sulfasalazine previously by a treating physician. So, what cases do you prefer to advise rheumatoid arthritis in the investigation panel other than Pianca Cianca?
It's a trick question, I guess, for me. And many times, what has been an experience with us is that RA factor or rheumatoid arthritis patients have joint changes or systemic disease pre-diagnosed when presenting as scleritis. So you are many times not the ones diagnosing rheumatoid arthritis. While reverse is the case in ANCA associated vasculitis, you are probably the person who is diagnosing an ANCA disease. They are not yet diagnosed with that disease. So I think this is very important point of differential, where ANCA you're diagnosing, RA probably they are pre-diagnosed.
Mhm. So, so you already mentioned that there is an association for systemic disease, like the lungs can be affected, or even the kidneys. Not might not be at the presentation, but later in life. So should we advise the patient's chest X-ray or HRCT while we are investigating the patient for ANCA-associated scleritis as well, at the same, I mean, at the same time, at the same point of time?
So yes, of course, we should ask the patients to get a renal and a lungs done at the baseline.
Okay. And what is your preferred choice of treatment for ANCA-associated scleritis? Sorry?
I think he asked you what is the treatment for the disease.
Yeah, I guess that's what I was referring to was cyclophosphamide and rituximab by far remain the front choices, and especially when the disease is combined, sclera with lung, sclera with renal, even sclera alone, necrotizing scleritis is one of the first indications for cyclophosphamide nowadays, while rituximab does remain a great choice if financial constraints are not there.
So thank you, Dr. Anu.
Thanks, Ronnie and Anu, but I think both of you completely missed the brief of the session. So while it is great to know what is the treatment and what we need to do for these patients, my question is very simple. I have a patient, Ronnie, you can stop sharing, of a case of, say, diffuse, just like the patient you mentioned, like diffuse, quite severe kind of an anterior scleritis. I am a general ophthalmologist. I would love to, but I have limited ability to treat this patient in terms of I don't really have too many rheumatologists to consult and so on and so forth. So, Anup, what is it as a general ophthalmologist I should definitely do for a patient who, because of, I know that it has severe pain and deep-seated redness and so on. So what should I do as a general ophthalmologist? How much should I treat? When should I refer? Should I do these tests that you mentioned? Or can I send it to you?
I think one of the tests that you should be doing is CBC ESR in all the cases, and ANCA, of course,
I would
is.
just like to argue, how will that help me if I'm referring the patient to you?
Yeah, I guess what I feel is high ESRs have a very high propensity for these kind of diseases. And the Cienca Pienca, I think, is not a street thief, it's a terrorist in disguise. And these are the ones where you see a necrosis and you get it, catch them, and then refer them. I think refer is the best option, I guess, if you are a general
In other
ophthalmologist.
words, if we class, so Dr. Ratnam has beautifully classified scleritis. It has classified and it has already been classified, and she's discussed this classification of scleritis. So some of the scleritis can just be the diffuse, non-necrotizing anterior scleritis, maybe even unilateral. So the message that the general ophthalmologist should, of course, be able to diagnose a case of scleritis versus episcleritis, for example. But should I, as a general ophthalmologist, so I have a diffuse anterior scleritis, unilateral, and the patient gives classical history. I'm very sure it's scleritis. So should I treat this patient? Should I investigate? Should I refer? This specific example. Dr. Ratinam?
Yeah. Actually, the question is to me. I didn't realize that.
Sorry.
Actually, I want to stress one more point, whether they had any previous history of injury or trauma or any foreign body fallen, because we see our lorry people carrying a lot, sand without covering. So many times, many people will just have foreign bodies, or when they are in two-wheeler driving, insect may fall. So history is important, very, very important. Let it be scleritis or episcleritis. If there is a foreign body fall or insect fall, first thing to suspect is infectious. So maybe they can give topical antibiotic also, if at all, if they have a history like this. If there is no history, and as Anup mentioned, basically ESR CRP is normal, they can try with the low dose oral steroid. 20 milligram every day for 15 days and 10 milligram for every day for 15 days. And they can also ask history of joint pain and the routine ones.
Yeah. That's very good advice, actually. So if I'm a general ophthalmologist, so at least the so-called quote unquote simpler cases of scleritis, once I rule out the local history of trauma or foreign body falling into the eye, rule out infection, and systemic history, if it's negative in terms of their symptomatology, then I can do a limited workup, like Anup also mentioned and you also mentioned, and I can treat this patient either with a lower dose of steroids or maybe topical steroids, and then if it doesn't get better, then definitely I'll have to refer this patient. But on the other hand, I guess almost everybody would agree that if I have a patient, I'm seeing this patient has bilateral, more severe, very aggressive kind of a scleritis, then as a general ophthalmologist, I can learn and treat this patient, but maybe it may be worth the while to refer this patient, initially itself to the specialist or to an institute set up where they have specialists for it.
The demography is also important. If it is a farmer, when every day they will have foreign body, history of foreign body fall, and they don't even register that.
Right.
So a farmer with a scleritis and pus pointing scleritis, they will not give history of foreign body, but there will be a foreign body we will be seeing.
Okay. So there's a strong possibility of infection based on the demographic, and I think we are coming in this presentation itself, we will have some cases discussing infection as well. Any other comments from any of the panelists for my persistent questions? I'm pursuing everyone to tell me I'm a ophthalmologist treating patients. I'm quite able. And I see a patient walking into my clinic, which is scleritis. What do I do? Partho.
What, ma'am? Sorry, I missed it.
So I said that you guys are not telling me what I want to hear. So I'm a general ophthalmologist. I'm quite capable of diagnosing scleritis. So I see a patient with scleritis walk into my clinic. What do I do?
Yeah, I think I'll take that discussion a little bit. That one thing we must remember that in country like India, no, so there can be cross reactivity with the tuberculosis patient, and C-ANCA can actually erroneously come positive. So one should actually remember this, because if you are treating a patient and only based on the ANCA, no, you should not treat aggressively. So
But I wouldn't do, sorry to interrupt, but I wouldn't do ANCA. Why? I don't want to go there. I want to see whether what are the guidelines for treating this patient?
Guideline for this treating the patient with scleritis.
Correct. In my clinic, in my ability of a general ophthalmologist. I'm not Dr. Partho from the UVI department of SN.
No, so first of all, you need to understand that scleritis can be an emergency condition, and you need to understand that what is the damage due to scleral inflammation. If it is going to be sight threatening or it's about to perforate, then it's not. I'll suggest any general ophthalmologist refer it to a higher center. Second, if it is a case of diffuse scleritis, you need to understand that these are the condition. Any kind of scleritis, when you see or diagnose, you have to remember that they have higher systemic association. So you have to rule out that whether this patient is having any systemic association or not. So best way for a general ophthalmologist is you just send all patients of scleritis to a rheumatologist friend of yours that this patient has been diagnosed with scleritis, and kindly rule out any systemic association if you are not sure. Because you should not do blanket testing like ANCA, RA without any proper clinical clue. And because if without any clinical clue you do some test, and if it comes positive, then you will be in soup. So it's always better to send this patient for a proper evaluation. And remember that you can't keep this patient on oral NSAID for an indefinite period. Sometimes these patients are have recurrent inflammation. So in that case, you can't treat only with steroid also. So they may need immunosuppressive. So scleritis is a condition you need to, even if you are a general ophthalmologist, you have to understand that you need a multidisciplinary care to handle this patient.
Very well.
Can I add one more point?
Yes, ma'am, please.
Without joint pain, when we send the patient to rheumatologist, most of the rheumatologists will say that there is no rheumatological disease. They will not go into the details of other systems. So we have to ask specifically, because one of our very, very important patient had a history of mastoiditis 4 years back and had mastoid surgery. Then patient had lung infection diagnosed as tuberculosis, treated for tuberculosis 3 years back. Then 2 years back, he had a severe headache, which was treated as fungal sinusitis, but in fact, he was ANCA positive vaginous granulomatosis. He didn't have joint pain. In between, he has gone to rheumatologist also. So when we send to a specialist, it is better we send to the doctor depending upon the symptom of the patient. If there is no joint pain, they immediately send that there is no rheumatological problem. Some of the rheumatologists do that.
But of late, at least in the city of Mumbai, we do have rheumatologists when we send that the diagnosis is scleritis. most
Yeah.
of the rheumatologists understand what is required from them, and they do
In
the.
metropolitan cities, yes. Suburban cities, no. They
Okay.
don't even have rheumatologists.
Okay, understood.
Right.
Archana,
Yes,
maybe.
ma'am, if I can add a point.
Yeah, because
For the
yeah, you might see patients coming in with a different demographic compared to what we see in cities or in tertiary eye care centers.
Yes, we do see, but for the general ophthalmologist, ma'am, I would like to add, like when they're in the periphery, they should actually also avert the lid and see. Sometimes there's a foreign body hidden there, and that is impinging on the sclera and causing, because we've seen cases like that also. And they are confused with scleritis and like autoimmune scleritis, and the patient is being given steroids, and there's a foreign body lodged in the lid with a history of trauma many years back. So that should also be ruled out by the general ophthalmologist.
Exactly the point that Dr. Ratinam was making, that I think we shouldn't just think about only immune-mediated scleritis. We must rule out infection, foreign body falling into the eye, so trauma. These are important causes. Mayur, you had a point to add here.
Just one thing from the general ophthalmologist point of view is that what is the timing of the pain in scleritis? If the patient complains that the pain comes in the after midnight or when the patient is just getting up, then that points towards possibly being a posterior scleritis. So in these cases, from a general ophthalmologist point of view, we can ask for a B scan to look for the T sign. Of course, there's a presentation on posterior scleritis that coming up, so I think that will be discussed there.
Yeah, no, very good point, Mayur. Excellent point. Anup, Supriya, and Ronnie, what would you add to this, my browbeating exercise of patient with scleritis, your general ophthalmologist? What do you do?
So
So
I have
one
sorry, go ahead.
Yeah, Ronnie, go ahead.
So, one point I'd like to add is proper documentation when the patient has first presented to a general ophthalmologist clinic. Because if the ophthalmologist wanted to start medication, either topical steroids or oral NSAIDs or low dose oral steroids, by the time the patient is referred or by the time the patient reaches to a rheumatologist or a uveitis clinic, the whatever the presentation that the patient had at the beginning, it might have resolved or sometimes self-resolving. So, what quadrants the scleritis is involving, whether there is any necrosis or whether there is any nodule, what are the type of anterior uveitis associated, whether there are any granulomatous KPs, whether there are iris nodules, NAKA, or any posterior segment findings. So, whichever the findings, clear documentation will help us, even if not just at that point of time, but even in the future. If there is a documentation that will help us guide towards the diagnosis, proper diagnosis.
Supriya, you had a point.
Yes, sir. So from a general ophthalmologist point of view, first, like we are discussing that dry eye is one of the closest differential, and we talk about joint pain. So if you ask any person, especially ladies, about the age of 45, 50, and you ask them history of joint pains, they invariably tend to say yes. But it's also important to ask them what is the type of joint pain, whether we are dealing with something like peripheral joints, which is more severe when the patient gets up early in the morning and gradually improves with time. And it is also important that we stain the surface. So once you stain the ocular surface, you get an idea as to whether you're dealing with something which is dry eye related inflammation of the eye, or it is not it's something which is scleritis. So I think staining of the corneal surface, it helps us to differentiate whether it is an ocular surface pathology, because the symptoms are of dry eye, particularly autoimmune, and the scleritis are more or less same when it comes to asking the patient with respect to fatigue and joint pains.
So I'm not sure if everybody who are uveitis specialists here will get that, because you folks will see scleritis and say it's scleritis. Whereas we're talking about where you see red eye, congested eye. Patient has history of joint inflammation, and the patient has dry eye. So it could well be a patient of RA, but it's not scleritis you're dealing with, but ocular surface inflammation due to dry eye. So that factor also has to be distinguished by a general ophthalmologist. You're on the right track in terms of the systemic, but not the ocular. So
I think
the
I think Supriya has actually raised a very interesting this thing. So it's very true. The inflammatory joint pain is characterized by that it worsens with rest.
Right.
Whereas that other non-inflammatory like osteoarthritis and all, no, with activity they get worsens. I think this can be a very important clue for picking up the inflammatory joint pain.
So we'll come back to this very interesting discussion where I'm browbeating all of you. I feel like Arnav Goswami actually. We'll come back to that. We'll go on to the next two cases back to back with the discussant. We'll move on to our BATS women now. So the next case is by Dr. Supriya, I think, and this is going to be discussed by Dr. Veda.
Are my slides visible?
Yes, your slides are visible.
Yeah. So good evening, everyone. Thank you again for this opportunity, Dr. Somshila and AIOS. So I'll be presenting a very interesting case where actually it was very difficult for us to diagnose whether it was an infectious pathology or an autoimmune pathology. And this was about a 63-year-old female who presented with pain and redness in the left eye for since 2 months, and there was no positive history of any trauma or surgery. This is the clinical picture when the patient actually presented to us. Looking at her medical records, a month ago, she had a similar episode of pain and redness. And at that time, because of the scleral nodule that the medical records mentioned, it was presumed to be infectious scleritis. The microbiological examination of the scleral scraping was performed, but that was negative. The serological profile was normal, and the patient was treated for immune-mediated scleritis and with topical and systemic immunosuppressants. The patient had initial resolution of symptoms for a month or so, but then again had a recurrence. And taking a closer look at the left eye, there was congestion, diffuse congestion involving almost nearly 3 quadrants. There was no AC inflammation or corneal involvement. However, there was severe tenderness. So looking at this clinical picture, we initially diagnosed it to be immune-mediated scleritis, and we started her on oral NSAIDs and topical steroids 1 hourly. The patient was asked to follow up at 4 days. However, because she felt better, she missed the follow-up and presented 2 weeks later with worsening of symptoms. There was the pain had increased, and there was, at this visit, as we can see here, there was a very well defined scleral nodule measuring around 3 into 3 millimeters involving the nasal sclera, and it had a typical yellowish appearance. There was the overlying conjunctiva was intact. There was no ulceration or discharge at this visit. We went ahead and did a scleral exploration and the microbiological examination of the scleral scraping. The pus sample that was seen on exploration was done, and that showed Staphylococcus werneri with no growth on culture. So the patient was started with a combination of topical fortified vancomycin and ciprofloxacin. Systemically, she was advised ciprofloxacin and oral paracetamol for pain. Over the next 2 weeks, the condition worsened, and as we can see, the patient developed multiple nodules involving different areas of the sclera, as it involved the temporal, as well as we can see here in the second clinical picture, there was presence of conjunctival ulceration with necrosis, there was discharge, and nearly all the quadrants were involved at this over the past next few days. So here we went ahead and again performed wound exploration. We did a 360-degree peritomy, scleral biopsy was taken, and at this time the scleral tissue was cultured, and that actually showed acid-fast organism and nocardia species. We started the patient on amikacin eye drops and systemic therapy. And gradually over the next few weeks, the patient did show signs of resolution, as we can see here. The amount of inflammation decreased, the scleral necrosis gradually subsided, and the patient was started on topical steroids at 3 weeks follow-up when we were certain that the patient just started responding to the antibiotics. And this was the clinical picture here this is the 4 months clinical picture where we see that the inflammation has nearly resolved. There is some amount of scleral thinning over here, and there was complete resolution, and the patient did not fortunately have a recurrence of infection, did not have a recurrence of this kind of an episode. So, just to highlight a few important points, that what was my learning from this case was that any patient who initially shows a temporary response to steroids and or who does not show a response, you should always keep a high index of suspicion of bacterial infection. Of course, the signs of bacterial scleritis include yellowish nodule, conjunctival ulceration, discharge, and scleral necrosis. Scleral exploration, I believe, is important to be performed early during the course because that helps us in debulking the infection. It provides sample for microbiological assessment and helps in better drug penetration. So my questions to the panelist and to Dr. Veda at this point would be, in the initial phases, in your experience, what are the signs that actually point towards infectious scleritis?
So Dr. Veda, it's for you now.
Good evening, everyone. So, can you hear me?
Yeah,
Yes.
we can.
There is no one single sign which will say whether it's a scleritis, like infectious or non-infectious, unless there is a pustule. Like you can actually see in your picture itself, like the first picture, if we like even we would have thought it was a immune-mediated scleritis in that patient. We would not have thought of infection. It looked like no diffuse congestion with no other evidence towards infection. So even a general ophthalmologist or a doctor in a cornea or in a UVR department will assume that it is a case of diffuse scleritis query, like maybe a non-infectious cause, and we will usually do, as already spoken, a TCDC ESR MAN2, like that's a routine thing, TPHA, and after ruling out, we start the patient on topical and oral steroids. So I think that is the same whether you are in a general ophthalmologist or in a specialty setup. But then obviously when the patient walked in with the scleral abscess or the evidence of infection, then everything changes. It's like, at that point, nobody can say that it is a non-infectious scleritis. So I think till then, a general ophthalmologist can manage on his own. If it is a non-infectious picture, they can do a basic investigation, start the patient on topical and oral steroid and manage the patient on the own. But when the patient comes back with scleral abscess or a pus point, I think then it depends on what sort of supports he have to decide whether he can continue the treatment at his place or he's going to refer the patient. So as said, without a surgical cleaning of the wound, you cannot come out with one treatment of the lesion or to the cause of the lesion. So you have to go for a surgical intervention. So if you have a support and in your setup, if you are a general ophthalmologist and if you have a support in your setup, then you can go ahead and treat it in your place. So you can do an incision and I think you can drain it, send for KOH cramps, and if possible, culture sensitivity and prove that it's infectious scleritis. But I think clinically, the first picture will not differentiate whether it's infectious or non-infectious. So I think I sort of answered it for both the general ophthalmologist and the like
Yes.
how to differentiate early immune-mediated and infectious scleritis.
Yes, you did. Thanks.
And
Dr.
so
Sanchita has a comment.
Yeah.
Yeah.
Yes. Can I ask it now or like at the end of the discussion?
Please ask Dr. Sanchita. We had you silent for a very long time. So
No, the infection part started right now.
yes.
Yeah. So I had this question for Supriya actually. Supriya, in your slide, you had shown that, the pus which was initially drained, it was like Staphylococcus warneri and no growth on
Yes.
culture. So
Yes.
until and unless it grows, you cannot identify the species. Even if you can, like, if it from the smear, you can understand the GPC in clusters, you can probably say it's Staphylococcus and not Streptococcus. But how did you go ahead and identify as Warneri? Was some
No,
sample NGS or something was done?
No. So I think I did not mention it correctly. There was no significant growth. So the microbiologist actually, whether it
Okay.
was significant or no, is what was reported.
Okay,
So
fine.
this could be either like having discussed with our microbiologist, Dr. Madhu, she was like, we cannot really conclude whether this is a contamination. I mean, I think even you can share your thoughts on this, whether Staphylococcus warneri is a contaminant or a common cell that we normally get, or it could be actually from the pus. So there was no significant growth is what I meant.
Okay, fine. No, she might have compared it with, the criteria of significance that we follow for all kinds of ocular samples, and then she might have concluded this. The thing that when you showed that Nocardia species was grown from the biopsy that was taken from this site of infection. So was any drug susceptibility testing done? I wanted to know that, like in the western part of India, what kind of drug susceptibility pattern you are getting for Nocardia. Probably, you could have shown that. It would have helped us on this part of the country.
Yes, I have missed that, Dr. Sanjita, but this is, I think, what we normally would start for any case of nocardia keratitis. From that is what we start as amikacin. We also started in
Yes.
this case.
Yeah, so we have a lot of internal presentations also on Nocardia as well as the eco classes, and repeatedly we have had this discussion that we thankfully consistently over the years on in vitro susceptibility testing for Nocardia isolates, we have seen that almost all the isolates are susceptible to amikacin. They are resistant to a number of drugs in vitro, but almost always susceptible to amikacin. So, that is a kind of reserve drug or safe drug that we have in hand. Now, if some fine day, like all the pathogens, they're becoming rapidly resistant to so many drugs. If Nocardia becomes resistant to amikacin, we actually don't have anything in hand. Somashila, if you remember, in one of the eco classes, we had this discussion. And then, it was a bit concerning that if amikacin becomes resistant one fine day, where should we go after this? So maybe all of us should gradually start thinking on this for Nocardia, because at least in the Hyderabad LVP, we get quite a large number of relatively significant number of Nocardia from different kinds of ocular infections throughout the year. So I think this is something that we should ponder about, especially when it is resistant to so many of the other drugs that we test in the
You're
lab.
scaring us now, Sanjita.
Yes.
Supriya, in the first presentation, so you had started intensive topical steroids every 1 hour.
Yes.
But did you also investigate this patient for scleritis? And
Because Dr. SS, the patient was recently had undergone the blood test, as per the medical records, we did not find the need to repeat it immediately. And because the patient was already advised the entire panel of connective, for immune mediated scleritis, which was everything was normal. And so we did
why
not
did you
repeat.
not start oral steroids? Conventionally, that's what we would have started for patients with scleritis. And usually, when at least those of us who treat scleritis, we don't resort to topical, certainly not 1 hourly topical steroids as a treatment.
So because because the previous medical records mentioned that there was a history, there was some scleral nodule, and they had gone to the extent of performing a scleral exploration with microbiological assessment. Considering the remote possibility of an infectious etiology, I think oral steroids was we first preferred to go ahead with topical steroids, and probably that is one of the reasons that actually triggered the nodule that was seen, and eventually the patient presented with a nodular lesion. I would like to know the experience of the other panelists.
In the very first slide clinical picture, though, the amount of congestion and of the conjunctiva. Of course, it's scleritis, no doubt, but there's a very boggy look to the conjunctiva. So these, with bitter experience, I've learned that these kind of cases are sometimes you can't when the patient comes in initially, you can't localize infection. And exactly what happens is when we start topical steroids, so we suppress the local inflammation, and then the tissue necrosis happens because of rapid multiplication of the organisms. And nocardia is something that thrives on when you use topical steroids. It starts even proliferating even better, actually. So but it's always in retrospect. So when you look at it in hindsight, it feels that perhaps this is one of the initial levels that you had. So in view of exactly what Dr. Ratinam said, to cut short to my story, what I'm trying to say is that sometimes it's better to start oral therapy, although oral steroids, we know it has its own side effects, rather than intensive topical therapy. because the inflammation will go down and the clinical picture will out itself over a period of time. But by adding topical therapy, if it was fungal, then it would have been even worse. Even nocardia also, or atypical mycobacterium, these are all drugs that actually the game gets changed when you add topical therapy. So for the cases when we are suspecting infection and the patient has severe inflammation, even if it's fungal, I think that giving oral immunosuppressants like steroids, not immunomodulators, for a few courses or for a few days is still better, so that the patient is symptomatically better, and then you can see what the picture is. So that is my take home in retrospect when I see these cases now. So we'll go to Dr. Ratinam and then to the other panelists as well to talk about this case. Dr. Ratinam, you're
I
muted.
just wanted to ask whether she did UBM at any point of time.
Yeah.
No, Dr. Veda, UBM was not done for this case. A B scan was done, but posterior segment was normal. But
Yeah,
UBM was not
because
done.
UBM would have
Good.
picked up two things. One is when there is infection which is not settling, always you have to look for a foreign body nidus. It may be the source of infection, and it's not. That's why it's not settling down. The source of infection is still there even after you have gone in twice and cleaned up the infection part. Two, you would like to see the scleral thickness. Sometimes when we go and do a deep exploration, if there is a scleral breach, the chances of perforation is again very high. So you would like to know what is your, like at what point you are working on. So we try to do a UBM, if it is available, to do a UBM whenever we go and do a explorative surgery in a patient with scleral abscess. So that was one thing I just wanted to know whether, and
Yeah, so
IV antibiotic.
One more very practical point given by our microbiologist is whenever we go for abscess draining, after abscess draining and cleaning, you put povidone iodine and keep it for a minute and then you wash. That povidone iodine will help you a lot in getting rid of these microorganisms. After taking a culture or a smear, when we clean the wound, you put a povidone iodine. That is very, very important. Back to Somshila.
So maybe what we can do is, if any other panelist doesn't have a comment just now, we'll go
If
to
I
the.
can add a comment.
Yes, Archana.
Yes, ma'am. For the general ophthalmologist, I think looking at the other eye gives a lot of information, whether it's autoimmune or it's infectious, because infectious is usually unilateral. And there may be telltale signs of having scleritis episodes in the other eye, and you may have some scleral thinning there. Then you can think of autoimmune in those patients.
So in other words, if it's recurrent or if the
Yes.
other eye is
So
having.
other eye has to be looked, not just one eye, and looked at, and then we can take a call in the initial phase when we're not sure whether it's autoimmune or infective, then the other eye also helps.
So it's helpful for us to consider it as immune-mediated scleritis. That's a good point. The only problem there is that you can have infection in immune-mediated.
Yes. But just when the initial phase is confusing, then the other eye does help.
Yeah, no, that's a very good point. So because there were so when it's very obvious with the pus point and everything, then I don't think anybody will have a problem in the diagnosis. But it's the initial phase, as Supriya showed, this diagnostic dilemma, when it doesn't look, you can't see any pus point. So it's like your guess is as good as mine. Is it infectious or immune mediated?
Also, ma'am, in our part of
No, sorry.
So here also we have like amikacin sensitive nocardia, and Pseudomonas also is fortunately till now sensitive to amikacin here. So don't know till
Then you're
what
very
time.
lucky about
So,
Pseudomonas.
Somashila, Sanchita here. I had another comment to add. So, if nocardia is being suspected by the this is for the general ophthalmologist.
Yeah.
So, if nocardia is being suspected by them for any of these cases of scleritis, then it's always better to talk to the microbiologist where they're going to send the sample, because nocardia, then the artificial mycobacteria, these are such thin kind of organisms, no, that until and unless you previously have it in your head that, well, this is suspected, it might be missed on microscopy. And microscopy is, within 2 hours or 3 hours, you will be getting the report. Whereas for culture, you have to wait for 3-4 days minimum to get any positive report. So, if you have a clinical suspicion of the pathogen, especially these kind of relatively less common pathogens, it's always better to talk to your microbiologist once when you send the sample.
So, Supriya, for when you did the scraping the first time round,
Yes.
you didn't get, at least we didn't get nocardia, but we got maybe some commensal or
Yes.
something. So, what are your take homes on how to send adequate tissue for microbiological evaluation? Because it's very important to try and get the bug.
Yes. So, first thing, like the space. So, normally when you perform a scleral exploration, you normally would tend to go perform a peritomy around it and then incise, give an incision at the site of the scleral nodule. And in that, so what the literature has reported that the yield of the pus when it comes to microbiology is very poor. So, all the papers have recommended it is better to culture the scleral tissue, so that can be taken either from the walls of the scleral nodule or the base of this thing. So rather than sending the pus sample, it is important that we send the scleral tissue, the necrotic scleral tissue, which shows a better yield when it comes to microbiology.
Do you take smears at slit lamp like how we do for cornea cases?
No. We send the sample for smear as well as culture. So smears, like from this case, I had taken the pus, the smear from the, like inoculated the smear, the pus from the 2 slides. And but for culture, it is, I think the first time we did not get is because I had not taken the scleral tissue. I had not cultured the scleral tissue, and it was just the pus sample that I had sent for the culture.
So the take home is that when we are taking up these patients for microbiology, the first point is that we have, at least I would recommend that not to just take the scrapings at slit lamp, because that is just the tip of the iceberg. You're seeing where the surface is eroded and the bugs are not going to be there maximally. They're going to be inside. So we have to take the patient up in OR because we have to open up the conjunctiva and debride that area and then send it for scrapings. And as Supriya mentioned that because it's embedded in the sclera, so take a small fragment of sclera, can put it on a culture plate. And I go one other step is to take some tissue and send it for pathology also. But you have to have a very good, as Sanchita pointed out, you have to have a very good dialogue with the microbiologist and pathologist, whoever you send the samples, that what are you suspecting and what they need to look for so that they can prepare the smears accordingly. I think we'll go to Archana's case.
I had one question, Dr.
Yeah.
SS, just if
Meanwhile, Archana, you can
quickly.
put up your
Yeah,
presentation.
does the pattern, the anatomical pattern in which this infection spreads has something to do with the type of organism? Like we see these multifocal pockets more commonly in fungus, nocardia, atypical, rather than a GNB, in your experience, like, or GNB usually will have a single, like a monofocal lesion as compared to the fungus and the atypical organisms.
Yeah. So fungal nocardia, atypical mycobacterium, these are slow to eradicate. They're slow growing, metabolically very sluggish. So what happens there is that they get chance to reside over there and our drugs don't penetrate fast enough because they're not active enough. And I'm sure even acanthamoeba. So these organisms, as you know, they escape the therapy and then they reside over there and then they slowly migrate through the loose tissues, and the scleral anatomy is very loose, as you know, it's disorganized tissue. It's not compact. So they migrate and then again they find another cooler place and they start growing over there. And then till that area starts ulcerating or it becomes, then the body inflammation starts working there and then you start seeing a nodule. So this is typically what happens. In the case of GNB, because of because of all the toxins that are being actively released, so there's tissue destruction happening massively. So there's no time for the organism to stay there and then go below, because the conjunctiva is just getting destroyed with the toxins. It's a very rapid process. And then other bacteria like say Staphylococcus and so on, they just stay in one place. So you'll have abscesses in localized places that's more likely to be bacterial. But these multiple can be either fungal or it can be one of the slow growing bacteria. That's what we have seen in many cases and in our case series that we had published. So, Archana, it's over to you now for your case.
Are my slides visible, ma'am?
Yes, it's visible.
Okay. So this was a case of Mycobacterium tuberculosis sclerouveitis. A 35-year-old male worker patient came with a history of redness, pain for the last 2 months, and he had this complaint of this yellowish white nodule on the white part of his eye. He had been diagnosed as autoimmune scleritis elsewhere and was on prednisone acetate 1 hourly, prednisolone acetate 1 hourly and some antibiotic drops. So at this point of time, for the general ophthalmologist, first thing is to decide whether it is autoimmune or infective. So if you look at the signs here, this patient had the visual acuity of finger counting 3 feet in the right eye, and left eye was unremarkable with 6/6 vision. So if you look at the lesion here, there was a yellowish white nodule, which was like an abscess. It was suppurative in nature. So that was a telltale sign of it being infective. Also, there were large iris granulomas here, and they were also more so on the side of the scleral nodule. The number was more on the side of which the nodule is. Then there was this hypopion, a streak hypopion if you look carefully, and this was dirty to muddy brown in color. Also, there were moderate to large size KPs on clinical examination. The B scan was normal and the left eye was unremarkable. So when I saw this picture, as Dr. Sanchita was mentioning, I called up my microbiologist and I told her that apart from my KOH and grams, we need an AFB 1% and 20% both. So she did a ZN stain and we did have this 20% AFB on the ZN stain. So now the next question was whether we were dealing with Mycobacterium tuberculosis or non-tubercular mycobacteria. Because on just the smear, I wasn't able to examine, tell. So maybe Dr. Sanchita will help us later how we can differentiate that on this smear. So keeping both the differentials in mind, I started the patient on fortified amikacin 2.5% and levofloxacin 1.5% eye drops, and the topical steroids were tapered. Also, a scleral de-roofing was performed. And while I was doing the de-roofing, I could just feel that there was a communication into the anterior chamber, like just a draining sinus kind of a thing. And I sent the scleral biopsy to a state reference lab as told to me by Dr. Sanchita, because she mentioned that this is a biohazard level 3 specimen that cannot be processed in the local lab and it has to be sent to a state reference lab. So I sent it to KGMU, the state reference lab in Uttar Pradesh, and there they did a CB-NAT and a culture. So CB-NAT results come in just 2 hours, and they told me that this is, yes, Mycobacterium tuberculosis, which is sensitive to rifampicin, and it is important to test the drug sensitivity here also. And in the meanwhile, we also got a PCR positive from the first scleral scraping that we had taken from the slit lamp, and it was positive for Mycobacterium tuberculosis. So now, is this just a form of extrapulmonary tuberculosis and ocular tuberculosis, or is it part of a larger picture and it is part of a disseminated tuberculosis? So Dr. Somshila had just alerted me to this point that yes, you could be dealing with a more severe and a potentially fatal condition, you should evaluate the patient systemically. So we evaluated the patient thoroughly, and fortunately the patient was immunocompetent, non-diabetic. And yes, on detailed questioning, he did give a history of on and off fever with abdominal discomfort for the last few months. So the physician worked him up and the chest x-ray was normal, but the CT scan abdomen revealed mesenteric lymphadenopathy. ATT was initiated, topical antibiotic drops were continued, and steroids were tapered topically. On day 10, the scleral nodule was resolving on the treatment, but we had an intense AC inflammation in response to the ATT, which obscured the AC details completely. So physician clearance for oral steroids was taken, and then oral steroids were started. At 1 month on tapering dose of oral steroids, this was the picture, ATT was continued. And at 3 months, the lesion had completely resolved. There was cataract, but there was, yes, persistent hypotonia that was there. The pressures then at 3 months were from 6, then they went down to 2. We had a shrunken globe and B scan. So we stepped up the oral steroids after physician clearance, and then the pressures came back to normal. So my questions from Dr. Sanchita are there any clues to differentiate non-tubercular mycobacterium from MTP on smear itself before we have the other reports? And then how do we process this biohazard level 3 sample? And what is the role of drug sensitivity for the general ophthalmologist? Because the NTEP guidelines have different treatment patterns for both drug sensitive and drug resistant bacteria. Also, for the expert and distinguished panel here, I would like to ask the ideal timing for starting oral steroids with ATT especially in cases where we are suspecting a disseminated TB, and also what should the ideal taper schedule be? Because I went through literature and there were different schedules, different timings. Some were starting concomitantly, some after 2 weeks. There were reports where they were not starting steroids at all. There were reports where they were starting within a short span of starting the ATT. So there are varying literature on that. Also, the taper schedule is also different in different reports. So how should we do it for our case? How should we individualize those steroids? And is there any role of a posterior subtenon steroid injection if there is persistent hypotony in chronic uveitis cases? Does it really help? And would also like to acknowledge ma'am, Dr. Amita ma'am from Lucknow, and Dr. Sanchita, Dr. Supriya, my pathologist here, who helped me through the case. Thank you.
Great case, Archana. We'll take it one by one. First, we'll go to Dr.
Yeah, Somshila, should I take my question? The voice broke off actually. You got muted. Am I audible, Archana?
Yes, you are audible.
Yeah, you are audible.
Okay, thank you, ma'am. Yes, so thank you, Archana, for the questions. So, on the smear, it's until and unless you have seen, like for the microbiologist, it might not be so difficult, but definitely for any other clinician, differentiating non-tubercular mycobacteria from Mycobacterium tuberculosis on smear is a tricky job. But you can take a few clues like, the MTB, though it's highly virulent, it's highly contagious, highly virulent. So, but on the smear, on acid-fast staining, it looks really very emaciated and very fragile kind of a pathogen. So that is because it has a lot of mycolic acid, the waxy layer in its cell wall. So even though even because of that, the carbolic fuchsin red dye retention is also very patchy. Thereby, it appears that kind of a fragile structure. Whereas in case of the non-tubercular mycobacteria, they're more or less, it is thicker, it is more uniformly stained on acid-fast staining, so that red stain is quite uniform. And of course, the MTB, especially in ocular samples, if you see, being paucibacillary, it's usually very less on the whole of the smear. The NTM, on the other hand, is quite a few, and many a times the NTM does not even take any stain, so you will get to see like vacuolated structures there. So on the growth, of course, you understand that MTB, it takes, if you're culturing it, it will require special media like LJ or the liquid media like Middlebrook 7H10 or 7H11, which have special supplements to support the growth of this highly virulent and fragile organism. Whereas in case of the non-tubercular mycobacteria, the usual blood agar, chocolate agar supports the growth, and the as you know, the divisions of non-tubercular mycobacteria like the rapid growers, the photochromogens, the scotochromogens, of which the rapid growers are most frequently isolated from the eye samples. And within less than 7 days, usually you get good growth on blood agar and chocolate agar itself. So this is another difference. If you do a PCR, so a conventional PCR for Mycobacterium tuberculosis is available in most of the diagnostic labs, and it targets the MBP64 gene, which is specific for MTB. So if you're running after extracting the DNA from your samples, if you're running a PCR on that with the target MBP64, the MTB will come as positive. NTM is, of course, will be negative. For NTM, there's a different set of target genes like the RPOB and the HSP70. So these are specific for NTM. So that is another kind of difference that we can do in the lab from the basic facilities that we have. And of course, if it grows, then from the colony characteristics, as you remember from your MBBS days, that the MTP will grow on LJ media as a rough, buff, and tough colonies, whereas the NTM will be very fine, dusty, dry kind of colonies on blood agar, chocolate agar itself. So one very important thing is, the MTB being a biosafety level 3 organism, because it's highly contagious, and most of the diagnostic labs to which you have access to have maximum BSL-2 facilities. So, like the non-tubercular mycobacteria is a BSL-2 pathogen. It can be cultured and then further identify drug susceptibility. Everything can be done at the BSL-2 labs. But for MTB, once you understand that, well, this is your MTB sample and probably your staff has inoculated without knowing on LG media or had been informed by the clinician that this might be MTB, please inoculate LG. After that, for the safety of everybody, just send the growth to BSL-3. It should not be processed any further in the BSL-2. In BSL-3, which is available in the state reference laboratories, the national nodal centers for tuberculosis, and a few private, research centers who work on Mycobacterium tuberculosis. So you have to have a proper communication when you are sending the cultures there, because either you want to identify properly and then do a drug testing. So that communication has to be with the team there very well. And there what they do is they go ahead further. Again, they will do a smear and staining. The smear will be stained with the gram stain, the Zn 20% acid-fast stain, as we do in our labs as well. And along with it, they also do the fluorescent autoimmune rhodamin stain. So autoimmune rhodamin stain, on that, it's very difficult to miss Mycobacterium tuberculosis because it's very well lit. The fluorescence is good enough. And especially for possibacillary samples like ocular samples, it's a very good test to get it directly from the smears. So the ones that we miss, we might be missing in our labs, they will catch it there on the autoimmune rhodamin fluorescent staining. Then next is the culture. If it has already grown on the LG media, they will also subculture on the Middlebrook liquid 7H10 and 7H11 liquid media. And then the further identification can be done there by the automated systems like the Bactec 900 or the Mycobacterium growth indicator tubes, MGIT. So also microscopic observation, drug susceptibility. So that is another automated method of identification of the mycobacteria from your samples and from your cultured growth. Then there's the, sometimes, it might not grow, then how do we go ahead? So it's the molecular methods which come into play, and the molecular methods are all the nucleic acid amplification tests. For example, as Archana already said, the CB-NAT, which not only identified it as confirmed the identification as MTB, but also identified the resistant genes. Similarly, I have already spoken about the conventional PCR with the target MBP64 gene, which is available in most of the BSL-2 labs to which you have access. The RT-PCR kits also are available in some of these labs. And then the state reference labs have the further facilities of expert MTB, RIF, where they can not only confirm the diagnosis but also identify the resistant genes in a period of less than 2 hours. Like, they can give you an overview of whether it is rifampicin resistant or not. Luckily for Archana, this was a rifampicin susceptible patient, and the treatment went on well with the first line drugs itself. We had published one case in which it was an extensively drug resistant disseminated tuberculosis, and the patient came to us because her eye got affected and it was the sclera was almost melting. So we collected the samples here itself, and we had inoculated in our lab only the LG media, and the rest of, and identified it on the smears because there were quite some amount of mycobacteria MTB on the smears, and send the rest of it to the state reference lab. So they have the facility of line probe assay. Line probe assay is another nucleic acid amplification based test, and within 24 to 48 hours they will be able to give you the identification and also identify a longer list of drugs to which it might be resistant. And if the reference lab or the national nodal centers, they have the line probe assay, even the second line drug drug testing. So you will get the full range of drugs to which your particular strain is resistant to, and accordingly you can modify the treatment. And luckily that patient, though she was extensively drug resistant, she magically responded to bedaquiline, which is now the magic drug. And unfortunately, bedaquiline also the resistance has come in for MTB. So the one question which she has put here, Archana, that the role of drug sensitivity, I think it's very important looking at the pattern of increasing level of drug resistance in MTB and your capability as an ophthalmologist to deal with the situation by following up the processing of microbiology processing till the end, including the drug susceptibility. You can actually contribute in saving the life of the patient. For example, for our patient, bedaquiline worked and her life was saved for 1 year. She was totally, there was no TB which was detected in her, but her eye got lost. It just melted out and had to be eviscerated. But at least we could save her life from the ocular samples that got processed. And of course, the whole genome sequencing and the next genome sequencing are available nowadays for understanding all, your query genes for drug resistance and your identification of MTB as well. So, yeah, yes.
Yeah, sorry, we're just running short on time. Thank you.
Yeah,
Sanjay,
if it is too much of microbiology, please tell
yeah,
me.
I think
Yes.
before we lose all our audience, because it is extremely important for us as ophthalmologists to realize that how we are helping the patient by detecting these diseases. And Archana, your case had disseminated tuberculosis ultimately, right?
Yes.
So
He had mesenteric lymphadenopathy along with it.
Okay. So I think we'll again bring to the forefront Dr. Ratinam and also Anup and also Partho and others, because this patient had had systemic tuberculosis and had a masquerade, sort of like an infectious tuberculosis etiology, in which she had granulomatous inflammation though. So when Anup said that it's very difficult in these cases, but the clinical signs that were there, you have the muddy hypopion and the granuloma in the anterior chamber, which you
All
could
those things
on the iris.
suggest TB.
Right.
So ideal timing for oral steroid, we have to wait for oral steroid. Maybe after 2 weeks, very low dose of oral steroid can be given. And tapering schedule also very, very slow tapering. And the role of PST, I will not go for PST in this case. Even if it is persistent hypotony, it may go for thysis. So only topical and oral.
Archana, you had the patient follow up with you after that last visit when the hypotony reversed.
Yes, ma'am. He completed his schedule till 9 months. So then his hypotony had recovered. I also did not use oral PSA, just the question that came to my mind. So I had just stepped up the oral steroids.
Did you perform surgery for this patient for that?
No, he's gone to Dubai to resume his work. He'll come back and then probably this year.
Right. So any comments from Anup and from Partho about this case, especially regarding the second part? Because microbiology has so been well described by Sanchita.
I think very nice and very challenging case. I'll just try to sum up very quickly that when we tell that the tuberculosis scleritis is very rare, I think sometimes we underestimate the actual prevalence of the tuberculosis scleritis.
No doubt.
Three condition I always try to rule out the tuberculosis. One is if it has any nodular form, especially if it is multinodular, then I definitely first rule out tuberculosis scleritis. Second, if the patient is having any history of immunosuppression, like patient is on immunosuppressive and the patient has come with scleritis, I try to rule out that. And number three is any other focal or like pulmonary, or as in this case, any other evidence of other organs are involved with tuberculosis. So these are the three conditions I try to rule out the tuberculosis scleritis.
So remember,
in the interest of time, will we go to the last case?
Yeah, the point I wanted to make here is that isolating the tubercular bacteria is a sort of a true kind of tubercular scleritis. Whereas we can have patients where we presume that that tuberculosis is the etiology because of the systemic features or some other features like the investigations and the imaging that are pointing towards scleritis. So we'll move to the final case for today's presentation, and that is by Dr. Fatima. Fatima, I apologize for the misspelling. And she's going to present, she's like the fast bowler here, and she's going to present on posterior scleritis, and Partho is going to discuss this for us. There are also a couple of questions which after this case and the discussion we'll just take up from the audience.
Can I start now?
Yes, please.
Good evening, everyone. I'm here to walk you through an interesting case of chemosis closed disclosure. A 47-year-old male presented with complaints of redness, pain, watering, and swelling in his left eye for 4 days duration. Prior to presentation to us, he consulted locally where he was treated as allergic conjunctivitis with IV phenyramine maleate and dexamethasone, and he was on olopatadine and ciprofloxacin eye drops. He had no significant systemic history or preceding ocular trauma or fever. On evaluation, his best corrected visual acuity in right eye was 66N6 and in his left eye it was 69N6. Intraocular pressure in right eye was normal, whereas in his left eye it was 26 millimeters of mercury, and there was a restriction of all extraocular movements in his left eye. External picture and anterior segment picture showed presence of severe conjunctival chemosis and congestion with an quite AC and occasional anterior vitreous space cells. Fundus evaluation in his right eye was within normal limits, whereas in his left eye there was presence of hyperemic disc with few SRF pockets and choroidal folds. Fundus fluorescent angiography showed presence of single pinpoint hyperfluorescence in early phases with increase in intensity in late phases. And in B scan, there was presence of widening of subtenon space with in all quadrants with a characteristic T sign and with a peripapillary choroidal thickness of 1.83 mm. So we evaluate. So an inflammatory workup was done for this patient, and it came to be negative. MRI orbit showed presence of circumferential thickening of ocular codes with an ill-defined T2 hyperintensity in the posterior tenon space and around the optic nerve. So based on this, we came to a diagnosis of posterior scleritis, and patient was given 3 doses of IVMP, following which his visual acuity improved to 66N6 and extraocular movements were full free. And on evaluation, the chemosis got reduced and SRF got resolved. Hence, the patient was maintained on oral prednisolone in tapering doses and oral azathioprine 50 mg TDS, and he was asked to review in a week. So at 1 week review, his visual acuity and intraocular pressure was normal. On evaluation, the presentation of the severe conjunctival chemosis got reduced completely, and the subtenon space widening got resolved, and the choroidal folds also got resolved. But he presented again 3 weeks later with complaints of redness in left eye while he was on 20 mg prednisolone as well as 50 mg BD dosing of azathioprine. And he also gave history of fever 5 days prior to this complaints. So in this visit, from the earlier picture of chemosis, there was a mild increase in chemosis with conjunctival congestion in the inferior quadrants. And the choroidal folds also got increased since the previous visit. And there was also increase in widening of the subtenon space. And in case of OCT, right eye was within normal limits, and in his left eye, there was presence of ellipsoid layer defects with multiple RP undulation suggestive of choroidal folds. Hence, a recurrence was noted, and we hiked up the dose of oral steroids to 60 mg per day and azathioprine to TDS dosing. 6 weeks post recurrence, again, the visual acuity and intraocular pressure was normal, and on evaluation, the posterior scleritis got resolved. So we kept the patient in the follow-up. But 8 months later, he presented with complaints of occasional redness, and he had stopped all the treatment on his own a week prior to this presentation. But at this visit, his visual acuity, intraocular pressure was normal, and there was no activity on evaluation. So we maintained the patient on topical NSAIDs and lubricants. 12 months later, he came again with complaints of redness and mild pain, but now it was in his right eye for a day. And his best corrected visual acuity intraocular pressure was within normal limits. On evaluation, he had conjunctival chemosis with congestion, and fundus showed choroidal folds in his right eye. So then now the scleritis strikes again in a contralateral eye. So we started the patient on oral prednisolone 40 mg per day with topical steroids. A month later, since there was no significant resolution, we added methotrexate 15 mg per week with tapering dose of oral steroids. 3 months later, there was resolution of signs with vision and IOP under normal limits, and hence we advised him to review in 3 months. But he presented again to emergency department a month later with complaints of redness in his right eye for 3 days. And on evaluation, he had presence of conjunctival congestion with dilated episcleral vessels, which was more prominent in the nasal, inferior, and the temporal quadrants. OCT at this visit showed minimal RP undulations with no SRF. Hence, he was added topical NSAIDs, and he was advised to be under follow-up. But he was lost to follow-up for almost 22 months, and then he presented again with complaints of redness, pain, and swelling in left eye for 10 days duration. At this visit, his best-corrected visual acuity in left eye was dropped to 618, and intraocular pressure was raised to 28 millimeters of mercury. Prior to presentation to us, he gave an history of fever with cough for a month duration, for which he consulted elsewhere, and he was evaluated for the same. And based on his Manto positivity, the patient was started on ATT elsewhere. And but 4 days after initiation of ATT, he developed this redness, pain, and swelling in his left eye. So they had withheld the ATT. And MRI brain and orbit was also done for him, wherein the left eye showed choroidal hyperintensity with choroidal effusion. And on presentation to us, he had a conjunctival congestion in his left eye, which was again prominent in the nasal, temporal, and inferior quadrants. And gonioscopy showed closed angles in the left eye, and fundus showed presence of an hyperemic disc with multiple SRF pockets, and corresponding hyperautofluorescent spots were noted in the FAF. And in case of fundus fluorescent angiography, there was presence of multiple hyperfluorescent pinpoint hyperfluorescence in the early phases, with progressively increasing hyperfluorescence in the late phase. In case of B-scan, there was again presence of widening of subtenon space with the choroidal thickness of 2.49 mm at this visit. So we re-investigated the patient, and all the workup came to be negative. Again, we gave 3 doses of IVMP, and post-IVMP, his visual acuity improved to 66N6, and his intraocular pressure was controlled with anti-glaucoma drugs. And patient was symptomatically better on evaluation, and we maintained the patient on oral steroids in tapering doses with methotrexate 15 mg per week. And on follow-up at first 1 month later, 8 months later, and at 16 months later, his best-corrected visual acuity and intraocular pressure was stable with no activity. So our overview of this case is that he presented at first with a one-line drop in vision and extraocular movements restriction with chemosis and choroidal folds. Based on this, we diagnosed him as posterior scleritis and gave IVMP followed by oral prednisolone. And after a week, his parameters got normal, but 3 weeks later, there was recurrence in his left eye with chemosis, congestion, and choroidal folds. So we hiked up the dose of oral steroids and azathioprine dosing to TDS. After 2 months, he had a resolution of posterior scleritis, but and 8 months later, he presented to us with stopping of his treatment on his own, but there was no activity, and we maintained him on topical NSAIDs. Again, 12 months later, he had a recurrence now in his right eye with chemosis, congestion, and choroidal folds, and was treated with oral and topical prednisolone. Since it was not resolving with that, we added methotrexate. Then 16 months, then 3 months later, he had a resolution, and hence he was advised to continue the same treatment. Again, a month after that, he had redness in his right eye, for which topical steroids were added. Following this, the patient had a loss of follow-up for almost 22 months, and then he presented again with a recurrence in his left eye with SRF, choroidal folds, and secondary angle closure. Hence, we gave 3 doses of IVMP followed by oral prednisolone and methotrexate. Now the patient showed resolution and is on follow-up for 1.5 years, and the vision and intraocular pressure is stable, and there was no further recurrences. Thank you. Now over to Partho sir for the discussion part.
Yeah, thanks, Fatima. Can you unshare your presentation?
Yes, sir.
Yeah, so I think it's very important. I think somewhere there may be confusion about that. The description of the FFA was made that it was not actually a case of CSR. If anyone is confusing with that, So I'll just try to highlight here the two important things. Here, if you see that leak were not increasing in size or intensity, which you can see in CSR. Here, the leak was maintaining. And second thing, if you read the textbook, it is said that in posterior scleritis, you are supposed to get the pinhead leak with placoid pulling of the dye. Now, sometimes you don't get the placoid pulling of the dye if the amount of the subretinal fluid is very less. Then you don't get that kind of classical picture. And so I'll just try to highlight that you have to understand that sometimes you can get this kind of picture where you see the conjunctival chemosis in posterior scleritis. As you can see here in this flow chart, that there will be increased capillary permeability and there will be release of pro-inflammatory mediators, and which will lead to the fluid expression in the conjunctival and episcleral tissue, leading to the conjunctival chemosis. Now, coming to the posterior scleritis, I'll just use 3 slides. I know we have very limited time. So the 3 slides I'll show and few pearls here. So if you look at the comment by Peter Watson, whom we can actually consider as the father of scleral inflammation. So he once commented that the posterior scleritis must be one of the most underdiagnosed treatable conditions in ophthalmology, partly because its manifestations are so protean and partly because the diagnosis is rarely considered. So here is 2 important catch. You have to remember that the incidence of posterior scleritis is much more than what we estimate. The second thing is that they have a plethora of presentation. That's why we tend to miss the posterior scleritis. Now, what happens here? We talk about many clinical muscular we often forget that the posterior scleritis can be a greatest muscular in terms of the clinical presentation. Now, if you see what are the causes of that, it can present with allergic conjunctivitis like picture. It can, as you have seen here in this case, it can have a mimicker of a proptosis. It can present with simple choroidal folds. It can have minimal subretinal fluid. All of us know, and nowadays we know that mass-like lesions are very common. So there can be giant nodular scleritis. And as we have seen in this case, Fatima's case showed us that so many presentation posterior scleritis can have. Lastly, it presented with angle closure glaucoma-like picture also. So then, because of the optic nerve involvement, it can actually mimic optic neuritis also. And of late, we are encountering a lot of drug-related posterior scleritis. For example, immune checkpoint inhibitor, namely the pembrolizumab and the nivolumab, has been actually associated with posterior scleritis like picture. The biphosphonates are known offender for scleral inflammation, and posterior scleritis can occur because of the biphosphonates. So the history of this drug use has to be ruled out in patients. There are 1 or 2 anecdotal reports about the evidence report of posterior scleritis following biweekly aflibercept and COVID-19 vaccines, but I'm sure this may be an anecdotal observation. Now, I'll just conclude with few myth and fact, which actually, because of which we miss posterior scleritis. The myth is that posterior scleritis is always painful, whereas we have seen in our study, we have seen that approximately 20% patients, the pain can be absent. Second is that posterior scleritis is always, we feel, unilateral. Yes, it is unilateral, but you have to remember that posterior scleritis rarely can become bilateral also and can confuse with age. Now, we feel that posterior scleritis is almost a disease of adult, but our case series showed that posterior scleritis is the most common cause of scleritis in children. Now, last, I know all people will talk about T sign and will try to correlate with posterior scleritis, but let me tell you, it is not pathognomic of posterior scleritis. In our series, only 70% of the patient with posterior scleritis had definite T sign. So don't exclude a case of posterior scleritis just because you don't see T sign in your ultrasound. That's all from my side.
Thank you, Pathu, for so crisply putting together the very, very relevant points of posterior scleritis. And I think most of us are recognizing more and more that not all cases will have classical T sign. So we have to consider the other symptomatology, as you mentioned. Maybe we can take some comments from Dr. Ratnam, of course, and then our posterior segment surgeons, which is Anup and also Ronnie. Dr. Maybe Anup, you could start and we'll wait for Dr. Ratnam.
Yeah, I had very basic points as you put it. So optic nerve T sign might not be present if the scleritis is not involving around the optic nerve, as simple as that. The second point is there are two types of posterior scleritis. Posterior nodular scleritis has often an overlap with large choroidal granuloma that requires a differentiation. ICG, FFA, OCT, B scan, a combination of this works out. While posterior diffuse scleritis, a large area of involvement, again has an overlap with a different entity, something like choroiditis, a stromal choroiditis like VKH, which might be asymmetrical. You might have in one eye, and you might think, is it a asymmetrical VKH or a diffuse posterior scleritis? So that those were the 2 points I wanted to highlight, and multimodal imaging, of course, solves them. The last point is sometimes there could be sclero-uveitis, where scleritis with uveitis might be happening. And you put up ICG and FFA pictures side by side. So if you have ICG involvement less than clinically seen involvement on a sclerouveitis, probably it's a primary scleritis, secondary choroiditis. Well, if you have a choroidal involvement which is very larger on, say, an ICG as compared to the subtenon fluid, it might be choroiditis predominantly. Thank you.
How much difference does this
Out
make
of
in
time,
terms of?
probably we can go to the last class.
Etiology wise, it would make a difference. Yeah.
This is the last case.
Okay.
So how much time, how much difference would it make for the, Anup, I was just asking the question that what.
So the etiology would make a difference. So if it is crossing, if it's a predominant choroiditis and a large choroidal granuloma, you would think of tuberculosis as one of your predominant diagnoses. And we saw in our series of tuberculomas that they can have a minimal scleritis and a subtenon fluid. So etiologically, it would make a difference.
So in other words, that while if it was not a choroidal granuloma, so you could, the patient just needs oral steroids. But,
Possibly, yes.
But if it's a choroidal granuloma, then you need to be more.
But think on, infectious.
Completely investigate. Okay. Quickly, Dr. Ratinam. So this was a case of very well presented, by the way, by Fatima. Thank you, Fatima. Very thorough. And then Partho also literally put together most of the points. So what is it that as a general ophthalmologist, I should look out for? How should I diagnose these cases and suspect posterior scleritis?
The pharyngeal congestion will be more than the limbal congestion. So we have to really avert the lid upper as well as lower, and we have to see the extremities. So even if we don't have ultrasound in a private practice, if pharyngeal congestion is all around, and also the patient is giving history of pain, it is posterior scleritis.
So more of a congestion, not in the visible palpable conjunctiva.
Yeah.
More posterior. So the blood vessels relative posterior, and you just see the sort of tip of the iceberg by affecting the upper and lower.
Upper end, and also dilatation and the disc edema with choroidal folds almost confirms.
That's a great tip. Actually, it didn't strike me to think of that as a differentiation. That's just a brilliant tip. There are a couple of questions in the chat which I just wanted to clear because the work answers are not visible to the participants. Anup, you had some points going back to our cases on MTB, infectious scleritis. If you could just quickly talk about your points for those cases.
Yes, I had a couple of points there, and one of three important points. One is when we speak infectious scleritis, Mycobacterium tubercular and viral scleritis remain a challenge to diagnose, especially if there are no cornea, anterior chamber, or retina and choroid features. It's extremely difficult to diagnose MTB and viral. And do not send this patient inadvertently to a rheumatologist. Then we will end up in much more bigger troubles. The second thing I wanted to say was Dr. Rima Bansal's paper. She showed that if a serpiginous-like choroiditis has a bit of a approximation to the optic disc, there is a possibility of a scleritis happening anteriorly. And I had one more point to add from my anecdotal observation is the infectious type of tubercular scleritis often having a cold abscess-like features. while kind of an inflammatory phenomenon happening sometimes years later after the ATT also. So that's the second point. The last point is the non-tubercular mycobacterium cases of the choroiditis that we have seen have been 1 to 2 days diameter of mid-peripheral regions, multiple either active or healed, and with or without scleritis. So those were the points I wanted to add for the earlier case. Thank you.
Okay, going back to the chat that we have, Dr. Verma has asked you, Mayur, so going back to episcleritis, what percentage of cyclosporin do you use? And so the first question is, what percentage of cyclosporin do you use? You're still on mute though. You're still muted, Mayur. Huh?
Yeah, so I will typically use the lower percentage. So I'll start off with 0.05%. And that is for two reasons. One is I really want to know if, patient is going to get some burning, stinging that's going to make him, stop the cyclosporin in the first place. And then if it's working well, then fine. If it's not working well, then I go to the higher dose.
And another question on episcleritis, Mayur, you could take that as well. Do we need to investigate a first episode or only in recurrent cases?
So typically, if it is a middle-aged female and like Partho said, she's come to the clinic because somebody has brought it to her mind that this is her eyes are red, then in that case, I would probably not investigate. There is one point about episcleritis that I really want to make, and that is that post-COVID, there are many people who come to hospitals, at least in general hospitals, with their masks on.
Right.
And we've had cases of episcleritis where we've told them to take off the mask and we've seen a malar rash there. And that can point towards SLE. It can also point towards rosacea. Rosacea is also a cause of episcleritis and scleritis. SLE, of course, is a multi-organ system disease, but rosacea is something that one can treat with a course of doxycycline or
No, it's a very important point because like Supriya had pointed out about blepharokeratoconjunctivitis.
Yeah.
And rosacea typically has episcleritis as one of its hallmark diagnostic feature. So Supriya has put down in her case that when she talked about infectious scleritis, they did have the sensitivity report of nocardia, Sanchita, if you're still there. And it was sensitive to amikacin. So I think that's what she's saying. Dr. Neha Mota has asked, what is the most common history associated with nocardia scleritis? Supriya, if you're there, or if you're not, then yeah.
Yes, Dr.
Yeah, okay. So the most common history associated with nocardia scleritis.
The most common, there's no particular history, as in I've not seen cases of trauma coming in with nocardia, but they usually have this chronic long-standing course, waxing and waning course, particularly when you give them topical steroids. The patient feels symptomatically better for a few days or weeks, and then suddenly, the condition worsens.
In the slightly earlier days, Supriya, when we used to have the way the sterilization used to happen, we used to have cases of nocardia scleritis following vitreoretinal surgery around the scleral ports or following other surgery where in the days when we used to reuse a lot of blades and instrumentations. But those causes are going down. I think now the most common history, probably Dr. Ratinam, would be agricultural background and history of trauma in the agricultural background for most common history for nocardia scleritis. So trauma of some sort would be there in these cases. So Dr. Mohammed has asked, and maybe either Archana or Supriya again for you. So when to perform biopsy? I'm guessing they're talking about the infectious cases. So when to perform biopsy? And secondly, how long will you give steroid before you re-evaluate the diagnosis?
A scleral biopsy, Dr. Archana, can I go first? Yeah, so the scleral biopsy, normally you would, when you're suspecting an infectious etiology, if you are not seeing, so you've gone ahead and performed a pus examination of the pus sample, and that has either come out to be negative, or even if it is showing some gram positive, gram negative, and you started the patient on antibiotic therapy, but you do not see a clinical response for over 2 to 3 days. And if there is something that actually any which ways requires your intervention, in the sense that you feel there's an infected buccal, or there is a glaucoma there's a glaucoma drainage device that is a source of infection, if any ways you're going to intervene, then it is good to take up the scleral biopsy and send it for microbiology and histopathological examination at the same time.
So in other words, if you have a patient of infectious scleritis, I think it's always good to perform a biopsy to get microbiology. Otherwise, you're not extremely sure. In case of very resource limited setup and you don't have any access to a microbiologist, or you don't have any other thing to do, then you can start empirical broad spectrum antibiotics to cover everything. But we are not sure whether the patient will respond, and there are too many organisms that you can cover. So I think always performing a biopsy for microbiology makes more sense. Supriya, the second question they asked is, how long would you give steroids before you re-evaluate the diagnosis?
So, steroids typically you would start once you have clinically seen that the patient is in infectious cases, that you are sure that the patient is responding to the antibiotic therapy that you have started, and once the actual ulceration and necrosis subsides, I think that is a good time when we can start the steroids. But again, these patients should be closely followed up, and if you're suspecting that there is significant amount of scleral thinning and necrosis, then more frequent steroids can again act as a double-edged sword, as in it can cause rapid perforation, be it the cornea or the sclera. So in those cases, we need to monitor closely basically these patients, and tapering can be done on weekly basis as you see the response. So I think in infectious scleritis, steroids are mostly for the inflammatory control. So it should be started only when you have diagnosed the organism and you've seen a clinical response to the antibiotic therapy.
All right, excellent advice. So while we wind up with our discussions today, I would like if Mayur could take us through maybe the top 3 or 4 take-homes for patients with episcleritis walking to a clinic. So your top 3 or 4 take-homes for the general ophthalmologist, Mayur.
So from an episcleritis point of view, obviously the top one is the one that I said, always dilate all cases of redness of eyes. You need to dilate the episcleritis to look at the fundus. That's number one. Number two thing is that in what I could probably call the garden variety of episcleritis, where they come in middle-aged females with a little redness, as Partho said, is probably wise not to really start the topical steroids first, because the patients would tend to
Right.
sort of
Right.
yeah. And probably the third thing is that in recurrent cases, or especially when you have a nodular episcleritis or they are painful, then one needs to start investigating.
So we'll go to Anup. And Anup, if you could summarize, what are your top take-homes for a patient with suspected immune-mediated scleritis? How should a general ophthalmologist treat these patients, manage these patients?
I think one of the first things that we saw was diagnosing that it is scleritis. That is the first one. Second, diagnosing infectious and non-infectious differentiation that we saw was one of the most important. Third point that we saw was infections like viral and tubercular could be problem. Fourth point that we saw was infectious, getting it through an infectious or a microbiology person is important. And then we saw that there are diseases like GPA, where you will definitely require multisystemic care. And they would want to be referred to multiple people actually seeing this patient.
So we'll move on to infection from the microbiologist perspective. Sanchita, can you give us your take-homes as a microbiologist? What should we do to make sure you get the appropriate sample? What information sent to you?
Yes, so Somshila, as I already said, these are all repeat points. So,
Top 3
communication.
take-homes. Yeah, assuming that people didn't listen.
Yes, communication with the microbiologist if you are suspecting a less common pathogen is important. And then they can even tell you that if any particular way you should be sending the sample. They are also informed that any particular media, special media needs to be used or any specific stain needs to be done. For
Right.
example, many a times when we get the information from OPD that you are suspecting nocardia or mycobacteria, and on the gram stain, we are not finding any organism, but because of your backend information, we again do a acid fast stain, and otherwise we wouldn't have done it. And many a times on the acid fast stain, we can detect your suspected pathogen. Other than this, I think the way we process microbiology samples and the way you all send is quite good enough for scleritis patients.
All right. So I'll ask Partho to quickly give us, though his was the last case, but in a small, and Partho, you presented fantastically. So of that, once again, if you can just repeat your top 3 take-homes for posterior scleritis.
Yeah, just number one, it's a high index of suspicion. Any form
Excellent.
can
Yeah.
present. Second is that you have to be very careful about understanding or interpretation. There can be combined scleritis involving both anterior and posterior. So look for the posterior segment in all cases of anterior segment. And number three, this requires systemic treatment and often recurrent in nature. So you may need to refer this patient because they may need immunosuppressive
Wonderful.
and other form of treatment.
Okay. So before we go on to Dr. Ratinam, who's going to summarize everything for us in a short way, any other panelist has any points before we go to Dr. Ratinam?
Actually, all the points are covered very well, and we should not keep them so late.
So those who log off will log off, Dr. Ratinam, but this is a great resource because a lot of people do review this, so we don't have to be restricted. Of course, we are a little slow on time, but
Yeah.
a lot of people do review this later. So because it's going to be a storehouse, these are very important points.
Yeah.
So
The most important take-home message is whether it is infectious or non-infectious, whether it is associated with systemic or not.
yeah,
So these 2 points are extremely important.
wonderful.
And after COVID, we definitely have more number of very non-specific episcleritis.
Yeah.
That every workup will be negative, and just even teardrops, they get better. So we have to be aware of the post-COVID episcleritis as well. So these are the 3 important points.
Thank you very much, Dr. Ratinam. And while I'm going to give the thank you note because Dr. Manoj Mathur had to log out, I'll request everybody to switch on their cameras, and maybe Mayur or somebody who's smart can just take a screenshot of all of us. It's my pleasant duty and privilege to thank All India Ophthalmology Society for giving us this opportunity to conduct this webinar on a topic that is close to our heart. Ronnie and Zara, if you can just switch on your cameras as well. And also, I think what has been fantastic is that all the presenters, including our very young presenters, have presented great, took a lot of effort, put together great cases for all of us. Maybe some general ophthalmologists might have felt they're a little bit too complex, but maybe when they go back and they get a chance to see it, they might get something to learn from each of every case. I'm really thankful to Sanchita also because she's our guest now on this panel, and I think having a microbiologist added a lot of value. So thanks to Dr. Santosh Honavar, Dr. Partho Biswas, Dr. Manoj Mathur for helping us put this together, and thanks to the tech team led by Sunil, who's always there to support everyone. So, Mayur, if you take off your camera, I'll take a screenshot actually. All right. Say cheese, everyone. Okay. Thank you very much. And finally, you're welcome to leave. Thank you for staying back for so late. Thank you, Veda. Bye to everyone. Thank you.
Bye. Bye. Thank you.